Very good. Alrighty. Hello, everybody. How's it going? Thanks so much for joining. We're going to go ahead and get started. I'm delighted to see everybody. For those I have not had the pleasure of meeting yet, my name is Eric Wilkin. I'm the Creative Marketing Director at Lightfully Behavioral Health. We want to welcome you to today's continuing education event, Interventions for Suicidality, Creating Safety Isn't Enough. And before we dive into the main presentation, I want to share some quick updates about our services at Lightfully. We specialize in primary mental health care services serving adults 18 plus and adolescents ages 12 to 17. Our programs are gender inclusive and we welcome clients of all identities across all of our locations in LA, San Diego, Thousand Oaks, and San Jose. And we pride ourselves on making quality mental health care accessible through extensive insurance coverage, high single case agreement rates, strategic location choices, and clinical excellence. And I'm particularly excited to share some additions we've made for 2025. First being our virtual PHP program with integrated psychiatric services. And this expansion allows us to reach more clients while maintaining the high standard of psychiatric oversight that those individuals need. Also, we now provide targeted treatment for schizoaffective disorder, and our approach really tackles the unique combination of mood symptoms and psychosis, empowering individuals to manage those symptoms and move towards a more balanced and fulfilling life. Also, for those clients who might be hesitant to a higher level of care or might need like more of a flexible option, we have what's called our short-term option. And this program offers intensive support across all levels of care, from residential to virtual, starting in just 2-week convenient blocks. And it complements existing outpatient treatment during high stress periods of life so they can continue coming to outpatient therapy. And it provides support through daily groups, individual therapy, family sessions, all led by our compassionate clinical experts. So if you think this sounds like it might be a good fit for a client of yours, our admissions team is ready to chat with you and make the transition as smooth as possible. Okay, cool. So on to some logistics. For reference, we're recording today's presentation and it will be available online afterward. Also, we'll address any questions that you might have during a short Q&A session towards the end of the meeting. So as questions pop up throughout the presentation, please go ahead and save those for the end of the presentation to pop them into the chat just so they don't get lost as the session goes on. So now it's my pleasure to introduce our distinguished speaker, Dr. Nicole Siegfried, Lightfully's Chief Clinical Officer. She brings over 2 decades of mental health treatment experience and serves as an adjunct assistant professor of psychology at the University of Alabama at Birmingham. Her expertise spans eating disorders, mental health, and suicide prevention with numerous publications and international speaking engagements to her credit. Her unwavering belief in recovery and dedication to helping individuals build lives worth living has really shaped our approach at Lightfully. So, without further ado, Nicole, I will hand it over to you for now.
Thank you so much. Welcome, everyone. I am so excited to see all of the hellos from across the United States. It's so much fun. I feel like so many states are represented. So glad that you're here with us. I'm joining today from Bend, Oregon. This is where I live, even though our programs are in California. I live in the Pacific Northwest, but in Bend. You'll also hear a little bit of a Southern accent. This is what people tell me. I don't think I have a Southern accent, but people tell me I do because I lived in Alabama for the past 25 years. So, oh my gosh, I just saw someone say go Vols for UT Knoxville. No, roll tide, roll tide. So glad that you could join us. I'm really excited. That might sound strange to say, to be excited to talk about suicidality and working with suicidal clients. I know that seems like a somewhat of a morbid topic here on a Friday, but my goal today is to bring some light and some confidence, competence with you all to treating this population so that you can feel more hope in working with these clients and less fear. So I get really excited and passionate about talking about this with you all. I'm going to go ahead and share our screen. Eric and I practiced this morning. So because I do have a little video at the end. So I'm going to make sure we do this right. Oh, look at us go. We've got it. Share sound. Let's do this and this. All right. Perfect. We got it. All right. So I do want to talk some today about creating safety. Obviously, safety is our number one priority, but I would say that often what happens when we focus so much on creating safety is we forget about actually treating the suicidality. And today's presentation is actually part one of two presentations. And so we can work with your team at Thriveworks to come and deliver part two that looks at how to work with clients with chronic suicidality and interventions that you can use. Today, I'm going to focus more on identifying clients at higher risk, what you do based on those risk levels, how you interact with someone who is struggling with suicidal symptoms, and how do you create a therapeutic alliance that makes them feel seen and known, and where they're given space to experience what is happening for them. So we're going to start with just first defining the challenge of working with clients. We'll spend some time on understanding suicide. This is something that I think is ignored oftentimes in working with this population. And is probably the most important thing that we can do, the most important aspect of our work in creating that therapeutic alliance. I'm going to talk about a more collaborative suicide risk assessment. If you're like me, well, maybe things have gotten better since I was trained in the dark ages, but a lot of my training was focused on identifying clients who needed hospitalization. And that is an important aspect, and we'll talk a little bit about that today. But a suicide risk assessment is much broader than just identifying who needs hospitalization. It's about what goes into the suicidal experience and what should be targeted in terms of intervention. So we'll talk about this more comprehensive suicide risk assessment that's beyond the Columbia. Maybe many of you utilize the Columbia as a screener, which is a very common suicide risk assessment. We utilize that as well, but we do utilize a broader, comprehensive assessment that is more collaborative and compassionate that I think you might be interested in. And then we'll talk about risk level interventions. And these are more of the immediate interventions for clients depending on their risk level. And then I'll give a little teaser to treating chronic suicidality, which is the part two of this presentation. I'll talk about what goes into that and the stance or the philosophy that we take in choosing those interventions. So one of the things I like to talk about is, first of all, like I said before, I think that this is a heavy topic. It brings up a lot for many of us in even addressing this topic. So I like to just start with just taking a deep breath and sort of centering ourselves into this space and looking at what we bring with us to this topic, or really more so what we bring with us in working with these clients. All of us have experiences around suicide. Some of them may be much more up close and personal than others, but we all have experiences in our lives that have shaped how we view suicide. And those views of suicide shape how we work with clients and work with the human in front of us. Gives me chills. So the first question is to ask yourself is, why do I think people die by suicide? What do I think goes into that? Do I think that there are genetic components? Do I think that there are sociological components, psychological components? What do I think about the person who kills themselves? Is there a certain type of person? There's myths related to suicide that a lot of us that are ingrained around it being something that's selfish, or something that is narcissistic even. So it's important to look at these beliefs that we may have in a compassionate way. There are reasons that we have carried those beliefs with us. And so looking at those in a compassionate way and without judgment, most of the time, these beliefs serve a protective function. We'll talk about that today, because this is such a feared presentation. We have beliefs that sometimes protect us from and create safety for us in how we view clients that show up this way. So, what are my beliefs about suicide? I've worked with many clients. Again, I lived in the South for 25 years, and it was common for people to think that suicide was sinful. And this was something that our clients often carried with them, and families would hold these beliefs, and often clinicians held these beliefs. So how does that shape the work that you may do? As an example, what have I learned about suicide in my life? Like I said, some of us have more up close and personal experiences of suicide. Maybe some of you have experienced your own suicidality, suicide attempts, hospitalizations. Many of us as clinicians have lived experience. And so how do those lived experience shape our work? I think about my own experiences in this work when my area of specialty is eating disorders. And I myself am recovered from an eating disorder in terms of lived experience that shapes my, how I present or show up. And when I first started doing this work with eating disorder clients at higher levels of care, like residential partial hospitalization, one of the things I noted, more so than in outpatient work, one of the things I noted was how many of our clients struggled with suicidality. And what you may or may not know is that eating disorders have one of the highest rates of suicide of any psychiatric disorder. So I found myself in a situation where it was demanded of me, or required, that I become more of an expert in suicide. I had very little training in working with clients who are suicidal. I got the training that most of us got in that day and age, which was probably 1 to 2 hours of how to send someone to the hospital was basically the intervention, was sending someone to the hospital. And the idea was you'd send them to the hospital and this would be resolved. They'd come back, you'd focus on their depression or their other diagnoses, and their suicidality would dissolve magically in front of you as part of working on those other symptoms. And what I'd found was that was glaringly inadequate in terms of really meeting these clients where they were. And at the same time, this was around 2007, my dear friend, who's also a psychologist, her husband died by suicide. And we were shocked. And as psychologists, we thought that we would have recognized the signs, the warning signals, and we didn't. We missed it. And this event was very pivotal in my work, of how do I work with clients to keep something like that from happening, where they feel seen and known enough that they can share how they're that they're having thoughts of wanting to die. So those are some of the things that shaped my work, and my specialization in this, because like I said, I felt woefully inadequate in meeting these clients where they were. And whatever that saying is of necessity becomes the mother of invention, I partnered with at that time a suicidologist. I didn't even know what that was. Someone who specializes in treatment of suicide. I partnered with a suicidologist for about 5 years, and really learned how to treat suicidality. She and I sort of did a speaking circuit, around eating disorders. And well, I hope that this is not coming up on my screen. Eric, is it my Teams chat? I put do not disturb.
I didn't see it.
Oh, perfect. Great. Okay. Oops, let me go back here. Sorry. Um, so, um, so I like to share what I bring into this work, and what shaped
I'm sorry,
me.
Nicole, to
And
interrupt you. We did
yes,
see the notification. I'm so sorry.
that's okay. Hold on one second. Let me stop my share. I don't want you guys to be bombarded with my Teams chat, because um, it will be going crazy in a second as everybody on the West Coast gets to work. Okay, let me just see. I'm just going to close that and see if that does it for me. Okay, let me know if share one window, not the full screen. I thought that's what I did. Okay, but I think I turned it off. So let's, if that happens again, I apologize. If that happens again, you all can tell me. Wait a minute. Okay, I do. I'm just sharing the screen. That's what I'm doing. Okay. All right. You guys, I'm not this technologically challenged. It's just like a little problem here. I'm stopping share. Hold on a second. Try one more. Human moments. Thank you. All right. We have one of our, let's try this again. One of our guiding, we call them shining commitments here at Lightfully, is we call it wabi sabi, which is finding beauty in the imperfection. And so that was a wabi sabi moment on my end. All right. So what what I want to make sure that you all are looking at in the work that we're doing today is what you've brought in. And I think of it as like bringing in a little backpack of experiences. I think it's also important to look at what how you've been trained around suicide and maybe some of the messages you've received from supervisors. Several years ago, I was giving a talk on suicide, and a woman came up to me at the break, and she was about my age. So she'd been doing this work for a long time, and she was a little bit choked up. And she said, I didn't realize this, but when we were talking about what we bring to this work, I realized that one of the first experiences I had was a client when I was an intern, a client who died by suicide. And when I was devastated and I felt like there was something I missed, there was something I should have done. Did I cause this? Did I was there something I could have done to prevent it? And so I went to my supervisor, and she said, I think my supervisor was really well meaning. But what he said was, she said, I remember it like it was yesterday, that he put up his hand like a stop sign. Because she said, I think I did this. I think I caused this. And he said, stop. I don't want to hear that. You did nothing wrong. We are not going to speak of that again. Like, there is nothing that you did. But what she said was that because he stopped the conversation and didn't allow for her to process through all of the guilt, which is common as a provider, it sort of stunted her processing around that event. And she carried with her a lot of guilt and a lot of blame that she never processed through. And because of that, she also said, I'm using her words, she carried with her a terror of working with these clients. And said, I just don't touch them with a 10-foot pole. The only reason I'm here today is I'm required and to be here. And I didn't realize how much that event shaped this terror that I hold. Whew, that gets me. So I think that many of us may carry with us some of those same kinds of experiences, again, from well-meaning supervisors who are doing the best they can with what they've learned about this. So just creating some space for that and some compassion for what you may have in your backpack today. Like I said earlier, my goal in today's presentation, I've been to many talks on suicide, and I hate the ones that use scare tactics about, getting sued and what's this going to do to your license. And, that is not going to be the focus of the talk today. I'm not going to share scary statistics. We are going to talk more about hope and compassion. I do want to set the stage, though, just to talk about this being a significant concern in the clients that we treat in terms of suicide rates and some stats around who is at risk. So we'll start there. Suicide rates have been on the rise. We know that there have been increases in suicide rates year over year since 1999. It's interesting that during 2020 and 2021, there was actually a little decrease in suicide rates. This was fascinating to suicidologists, people who do research in this area, because what we know was going on then was COVID. And you would think that with COVID that there would be maybe an increase in suicide rates. And actually, this is correlational, but there was actually a little bit of a dip. And one of the theories is that during that time, even though we had a lot of fear as a nation and there was a lot of stress as a country, um, there was also a lot of all of us are in the same boat, and there was a lot of shared fear. And one of the theories is that that a lot of people that might have been feeling very alone during that time felt a sense of togetherness that may have been protected. So that's an interesting um, perspective. I find it interesting. Um, but since that time, there's been again a blip back up in those suicide rates, back up to the same levels and the same increases that we'd been seeing before. One of the things that you all are probably familiar with is that females are more likely to make suicide attempts. Males are more likely to die by suicide. Why is that? Females typically choose less lethal methods than males do. Males are more likely to use firearms, which is the most lethal um, method to use in a suicide attempt. Most people are in a depressive episode or demonstrating some kind of psychiatric disorder at the time of their suicide. At least 48,000 people die by suicide each year in this country. And this is what always gets me. 3 out of 4 people who die by suicide are not in treatment at the time of their death. There are certain populations that may be at higher risk for suicide. We know that our LGBTQ folks are more likely to have suicidal ideation and suicide attempts. Our youth, our LGBTQ youth, are 40%. 40% of them have seriously considered attempting suicide in the past year. There are also races and ethnic groups that are more at risk for suicide. Our Native American, American Indian folks have the highest rate of suicide of any racial or ethnic group. Something else that is maybe interesting to people is that in terms of age, if you had someone in front of you, a teen versus an elderly man, a man in his 60s, let's say, the man in his 60s is going to be at higher risk for suicide than the teen in front of you. Sometimes that surprises people because when we think of teens, suicide is the third leading cause of death in teens, and it's way down on the list in our older age groups. But that is because there are other things that are more likely to kill you when you're in your 60s: heart attack, stroke, things like that. Whereas with our youth, it's accidents. Are and drug overdoses are the only other two that come in front of suicide. But in terms of who's at higher risk, males in their 60s are the highest risk age group. So let's start with some myths about suicide. Some of these you all know that these are myths. Others might surprise you. So first, the first myth is suicide is an act of cowardice. Now, I'm not regaling suicide as a courageous act, but when we have this myth that it is something cowardly, it may block us from recognizing who's at risk. it takes a tremendous amount of fearlessness to kill yourself. In fact, individuals who've desensitized themselves around death and have less fear around death are at highest risk. So we need to think of it in this way. When we think of it as something that's cowardly, we might have an image of someone who actually is not as at highest risk, high risk of suicide. We also, another myth is that individuals who die by suicide are fully intent on dying. I've got another myth in here that kind of goes along with this, that is that clients or individuals, that once they make up their mind, there's nothing you can do. And this simply isn't true. So there's a documentary called The Bridge. Many of you may have seen it. It's a little bit dated at this point, but it was a documentary that interviewed people who had attempted suicide by jumping from the Golden Gate Bridge. At one point, and this is a picture of that bridge. At one point, the Golden Gate Bridge was a suicide destination spot. And the reason for that, for a long time, was that it's a high bridge, for one thing, and the Pacific Ocean is not a gentle landing ground in terms of the waves and currents. But also, for a long time, the Golden Gate Bridge didn't have protective railings. It was thought that these railings would interfere with the aesthetic of the bridge. And so it was one of the last bridges to get protective railings. It does have it now. And so this was a destination. So in that documentary, if you haven't seen it, many people talked about their attempts. And a famous individual who attempted suicide by jumping from Golden Gate Bridge, let me go to the next slide and I'll come back to this, was Kevin Hines. And some of you may be familiar with Kevin because he's an advocate now in terms of suicide prevention. And his story is so poignant. There's a quote here where he said, the millisecond my hands left the bridge, I had an instant regret for my actions. I bobbled up and down in the water and said, God, please save me. I don't want to die. I made a mistake. And so I use him as an example that many clients who've attempted suicide have regret and immediately think that they shouldn't have done this. There are others who wake up in the hospital and say, oh my gosh, I never thought I would have woken up by what happened, and I wish I was still dead. There are those individuals, but it's important to know that there are those like Kevin, and this is more common than not, who regret the attempt. His story goes on. If you've ever heard him speak, it's really miraculous because he'd broken so many bones. He wasn't really able to doggy paddle in the ocean. I can't remember if it's a sea lion or a seal or I get those confused anyway, but came to him, or maybe it was even a dolphin. I'm not sure. Some kind of marine animal came and supported, oh, it gives me chills, came and supported him until the Coast Guard could rescue him and kept pushing him up until he could be rescued. A truly beautiful story. And he, again, now is an advocate for suicide prevention. Other myths, suicide rates peak during the holidays. This is one I believed for a long time. And even with clients, thought, oh gosh, it's the holidays. This is going to be a higher risk time. But actually, this is a time that suicide rates sort of dip. not to think that, oh gosh, I don't have to think that this is a risk for my client because it's December. But it's more to think that um, that spring is actually the time of the year that's associated with higher suicide rates. Why is that? Well, one thought is that actually over the holidays, clients often, because it's suicide is not a selfish act, often think, I don't want to do this to my family right now. I'm going to actually see if I can make it through the holidays. And often they will. Um, and then often they'll say to themselves, okay, maybe things with the new year will be different, sort of new year, new me. And so maybe maybe I'll feel like my life is worth living. And so I'm going to give it a chance. And so often then after a month or so, a couple of months, people say it's not working. So spring is often a time that there's a higher suicide rate. Also, one of the things that we know can happen sometimes is that in the depths of depression, people are so paralyzed that they cannot even muster up the energy to kill themselves. And sometimes with spring, it can provide a little boost or burst of energy that makes people just well enough to kill themselves, so to speak. This is something we see sometimes even with when clients first start antidepressants, let's say, and they are coming out of that paralysis and psychomotor retardation, that they get just enough better to kill themselves. So we need to really be thinking of that time for our clients as a higher risk time. So it's inaccurate to think of the holidays as the highest risk time. Another myth is that most people leave a suicide note. Actually, only 20% of people leave a suicide note. And the reason this is important is sometimes people will dismiss, especially families may dismiss the seriousness of someone's attempt because they'll say, well, they didn't even leave a note. So this was more just for attention, let's say. So, like I said, most people don't leave a note. I always share a story about Thomas Joyner. And those of you who are interested in learning more about why people die by suicide, you may be interested in his book called Why People Die by Suicide. Thomas Joyner, we'll talk about him more today. He's a leading suicidologist, and he's very interesting in that he has lived experience as well in terms of his father dying by suicide when Thomas was in graduate school. And so he was already studying depression, Thomas was, while he was in graduate school. But when his father died by suicide, and it was such a shock to the family, he diverted his efforts and focus to suicide specifically. But what he talked about was that this was such a shock to him and his family. They never knew what happened or why, or what factors came together to make their father do this. And so he didn't leave a note. But years later, the police contacted Thomas to say, hey, I might get some of the details around this wrong of how long it was, but at some point there's enough time that passes that they get rid of what's in the evidence box for the police do. And so that's what was happening. And they said, we have these things that we had in evidence and you may want them. And so he said, yes, I do. And so when he got the things that were in the evidence box, there was a note, there was a suicide note. And he was like, oh my gosh, finally, I'm going to know why my dad did this. And he said, it was kind of gibberish. It made no sense. It actually made him have more questions than answers. And so I say that because I think we sometimes put a lot of focus on a suicide note, but even those who leave a suicide note, it doesn't provide a lot of rhyme and reason as to what happened. And then I already talked about, that there's nothing that you can do to stop someone who really wants to kill themselves. One of the, or the number one preventive, it's still coming up. So sorry, guys. The number one preventive factor in preventing suicide is means reduction. And so when we can create a safe environment and reduce access to means, then this prevents suicide. So this sort of disputes this myth that there's nothing you can do to stop someone. Some more important or additional stats that are important. Suicidal behavior is the most frequently encountered mental health emergency and generates high fear among providers. It's the most feared presentation that providers report. And again, these are not my scare tactics. This is the only slide, but this is important to know. Most of us will have experienced either a death by suicide or suicide attempts in our clients. And so we need to talk about this. We need training around it. We need support around it as clinicians. So like I said, 1 in 5 of us will lose a client. 70% of us have had clients have a suicide attempt. And the majority of us have received less than 4 hours of formal suicide training. Here's good news, though. This has changed in the years of me doing this work. When I first started this work, the average number of hours that providers received in terms of training was 2. So we've doubled that in the last 15 years. So that's promising. So this is information that shows that we are making some progress. 10% of patients who have suicide attempts account for 30% of mental health resources. So there's this phenomenon, the revolving door phenomenon, in which clients go in and out of the hospital. And the reason for that, from my perspective, is that we think of hospitalization as treatment. And that may sound somewhat radical to say. Hospitalization is not treatment. Hospitalization is safety. And so when we shift our thinking to move away from thinking, when my client goes to the hospital, they're going to be treated, they're going to come back, now they're no longer suicidal. When we shift our thinking away from that, it may reduce this revolving door phenomenon. I'm also going to say something that really might be radical, which is hospitalization is not the end all be all. I want to say it in even a more radical way. I will say that part in a second. But when people leave the hospital, their risk for suicide goes up by 200%. Now, that is not to say that hospitalization causes suicide. I have a study I'm going to share in a moment that just came out, though, that lends itself to the idea that hospitalization may cause suicide. That's the radical thing I'm going to say. But what we know with this previous stat is that it may be that the clients that are patients that have gone to the hospital get just enough better to kill themselves, or that they really were fully intent on dying, or that they didn't have the resources they needed when they left the hospital and didn't have enough support. Those were the things that we used to say. There was a study that just came out in July that is the first study of its kind. It's a quasi experimental study. We can't randomly assign people to inpatient hospitalization or not, right? But what this study did, it was a very sophisticated, elegant study. What it looked at was patients who were on the cusp of needing hospitalization. And these patients where some providers would send them to the hospital and some wouldn't. So they compared those patients that were in this category where some were sent, some weren't. And what they found is the patients that were sent to the hospital were more likely to die by suicide than those that weren't. They also found that within the 3 months after hospitalization, they were more likely to be incarcerated and have other negative sequelae associated with hospitalization. That is like, I know that's really eye-opening. I'm not at a point to say, don't send someone to the hospital. I would say hospitalization is needed to create safety. It's the ultimate safety precaution. And there are times when our clients need that level of safety so that they can get back on medication, so that they can get sleep and stabilize enough to do the work outpatient or at a lower level of care. But that's where the work is going to be done, not at the hospital. So that is somewhat of a radical thought, but it's an important one and an important aspect of the work we do, because we are it. We as at the lower levels of care, we are who should be treating suicidality and will be treating suicidality. All right, so let's talk about the suicidal mind. What I tell people when I do this training is this is the most important slide of anything that we're going to talk about today, is how do we understand suicidality? Why do people die by suicide? How do we understand this human in front of us? First, suicide is a decision. We need to look at it in this way, of a decision made by a person seeking relief from psych ache. This might be a new term for you all. It's a beautiful term, I think. It was coined by Ed Schneidman, who was the first suicidologist. He was the founder and the father of the American Association of Suicidology. And he said that there really wasn't a term for the experience that people have of being suicidal. So he came up with it. And psych refers to the cognitive and emotional experience of being suicidal. And what you'll see in clients who are experiencing psych is often they'll even have their hands to their head, and they'll be sort of rocking like this. Or they may have their hands to their heart. But it is, they'll talk about a physical pain almost that is associated with the ruminative thought of wanting to die. And they'll also talk about a physical pain that is in the gut or in the heart. And I often utilize the word psyche to give a client language for what they're experiencing, because often there are no words for this experience of where we are wired as humans to protect, to live. So the experience in which you want to go against our evolutionary protectedness there are no words. Psych is a word that can be helpful for clients to describe that experience. What we also know, and we'll go into this in a little bit more on some of the next slides, is that those who die by suicide often feel burdensomeness, or experience burdensomeness, feel disconnected, and they have a sense of fearlessness around death. So we'll talk about these three factors because these are things that we're going to want to, as clinicians, start to be looking for in that client in front of us to be an indicator of risk for suicide. Individuals who are suicidal experience something called constricted thinking. This also is one of the most important aspects of understanding the suicidal mind and can also provide some relief and some compassion and understanding for our clients. So, constricted thinking is a protective factor, evolutionarily protective factor that goes awry in something like suicidal thinking or suicidality. So I give the example oftentimes of, like, if a bear were to come into my office right now, God forbid, um, I would experience constricted thinking in an adaptive way. So everything would fade to the periphery. I'd forget that I was doing a presentation. I wouldn't care that I was doing a presentation. Everything would focus on this bear and whatever you're supposed to do. I also always forget whatever you're supposed to do when you see a bear, play dead, growl, I don't know, whatever it is. I'd be thinking of what I was supposed to do and not thinking about everything else around me. That is adaptive. And our ancestors who had constricted thinking in those situations survived and passed on their genes. Unfortunately, that tendency causes problems in other situations. So if a person is suicidal and they're experiencing constricted thinking, everything goes to the periphery except for the focus on dying. And actually, it seems like the only solution, the only solution to my problem is to die. There are no other options on the horizon for me. This can be really difficult for families and clinicians at that, because we see the whole horizon of possibility and of solutions. And so we'll often want to say, oh my gosh, but this isn't, that doesn't have to be the decision. That doesn't have to be the solution. There's all of these other possibilities, but they can't see those. And so, as part of working with clients, when you have a good enough rapport, you can remind them that they're experiencing constricted thinking and remind them that in that moment, they're, by virtue of the suicidal experience, their mind is working against them and they're not seeing all the options, even though they're there. So I also share an example or a analogy, I guess, as related to this. I don't know if any of you have been to the 9/11 Museum. If you haven't, you should go when the next time you're in New York. It is a really important experience to visit there. But one of the art installations that they have, if you've been there, you know, is they have a section where they have pictures that are blown up of the people who ended up jumping to their deaths. Those people did not die by suicide. Those people were going to die. They just chose the route by which they were dying. But I think there's something important that we can learn from those individuals. And when I was in that section of the museum, I sat there and stared at them and, like, what was going through their head? Like, oh, I can't even imagine how horrific. But I also thought, what would have been the difference between them and someone else who was jumping to their death from the Golden Gate Bridge, let's say? And I really couldn't come up with a difference. in how they, in how, in the experience that they were having internally. So I thought about our clients that are experiencing constricted thinking, and I the image that I have often is that they are in a burning building similar to the World Trade Center, and that they feel as though there is no other option. It's either that I stay in the building and I'm essentially burned alive, or I, in terms of the psychic and in terms of this emotional pain, or I jump to my death. And that is the decision it feels like at the time of a suicide attempt. And again, like I said, it's very difficult for us because we have a map of the building as a provider, or family members have a map of the building. And it's as though they're sitting there saying, oh my gosh, don't jump. There's an exit. You just can't see it through the smoke, but there's an exit so that you can get to the bottom floor. And this is, though, something I give this analogy to our clients. And I say, during those times when you want to kill yourself, there is an exit that you can't see. And that is the time that you rely on your family or a trusted other, or you rely on your therapist, and you don't jump because you just can't see the exit. So, with clients that I work closely with for a long time, I will often say, and some of them have chosen it as a mantra, the worst time to kill yourself is when you're suicidal, which it sounds a little antithetical, but it is the worst time to kill yourself. You're not seeing things clearly by virtue of being suicidal. And then finally, it's important to know that clients who do attempt suicide are not doing this to get attention. Another shift, or another way to look at it, is it may be that it's help seeking. It may be that there's no other option that they see except to try to kill themselves. But it's not attention seeking. This is very much a risky conceptualization when we start to go down this path. And I see many new therapists conceptualizing suicide attempts in this way for our frequent attempters. And the reason I think this is a dangerous conceptualization is, what happens when we start to think that something is attention seeking? We ignore it, right? When someone's doing something for attention, the intervention is to ignore it, which is the worst thing that you can do in the case of someone who's really trying to seek help. So when we start to feel that way, and we are human, we will feel that way. We at some point will be like, oh my gosh, here they go again. This is more of a reflection on us as a clinician and where we are in our practice than the client themselves. So when this comes up, what I tell clinicians is, it's a time for us to pause and say, okay, what's coming up for me that's my go-to conceptualization for this client in front of me? Sometimes it might be I'm burned out. Sometimes it might be that I'm scared. Sometimes it might be that I'm frustrated because I see options for this client and they aren't listening to me. They aren't seeing the light. But that's me. That's my stuff. But that's okay. We can process through that in supervision, and in with our colleagues. But it is not an indicator that we should ignore what's in front of us. So the conceptualization, there are many theories of suicide and why people die by suicide. The conceptualization that I use and that we use here at Lightfully is Thomas Joiner's theory, which is the interpersonal theory of suicide. And what Joyner says is that three factors converge to place a person at risk for suicide. The first is a sense of burdensomeness. Now, burdensomeness can take on what I say different flavors. So we have the classic burdensomeness, which is my death is worth more than my life. My family, my family would be better off without me. But I also see burdensomeness show up in different ways. Psychache is a burden, carrying that emotional pain that feels like a burning building, that you're in a burning building, it is a burden. Another burden that I see in our clients is the burden of therapy itself. So I see this a lot of times with our clients with PTSD that are tortured by their trauma. And when they're told, it's going to take time for us to work this through, and it's going to be, some therapy, some hard work and some hard therapy around this. What has to be done to get through that, and the length of time that it may seem that it takes, feels burdensome to our clients. And so I've seen that happen as well. Is that what's in front of me to get to the other side feels insurmountable. So those are some things that we should be thinking of when we're looking for whether or not burdensomeness is present in our clients. A second factor that we see is what Joyner refers to as thwarted belongingness. Now, I've never had a client say, I think I'm experiencing thwarted belongingness. That's academic language. We don't see that really in practice. What we see more so is clients saying, I feel misunderstood. I feel unseen. I feel disconnected. I feel like no one really knows me. Those are things that should start raising our radar that a client is experiencing some type of thwarted belongingness. What I'll tell you though, and this always is something that gives me some hope, is that the number one way to quell suicidal ideation is through connection. So I talk about the number one way to prevent suicide is means reduction. If you don't have the way to prevent the way to kill yourself in front of you, you can't do it. But the number one way to prevent or to soften or dissolve suicidal ideation is through connection. And I'm always like, oh, got it. I think if that's all I have to do, I mean, we were trained for this. We know how to connect to a client. We know how to make them feel seen and heard and known. And we can even do that sometimes in the first session. So that's so powerful to think that what feels often so scary to us, that we have a way within even the first session to start to dissolve some of that ideation. So yes, thwarted belongingness is one of the main factors, but it's that contributes to suicidality, but it's also one of the first ways that we can get some traction toward coming out of the suicidality. The third factor, and this is what I call the tipping point factor, is what is called acquired capacity for lethality. So this is important. This is something that people don't talk about a lot when they talk about suicide. We talk about warning signs. We talk about risk factors. But we need to understand acquired capacity for lethality. Acquired capacity for lethality is comprised of two parts. The first is a fearlessness around death. For me to kill myself, I have to be able to go against every fiber of my being that is wired for protection, that is wired to keep me from dying. So I have to have that fearlessness. And the second is pain tolerance. So I have a picture here. This is an algometer that measures pain tolerance. Um, in some of the studies that we've done with Joyner in his lab, we've looked at acquired capacity for lethality and looked at pain tolerance. So what this measures is pressure. It doesn't leave a mark, but it measures the degree to which you can withstand that pressure, and the higher the algometer reading, the more that you can stand. And so it's a good measure of that. So that piece is important. You might have thwarted belongingness, you might have burdensomeness, but if you don't have this acquired capacity for lethality, you will not attempt suicide. So we've got to look at this factor. So these three factors come together to place a person at risk for a serious suicide attempt or a death by suicide. So let's look at this in a different way. So we have over here on the left side desire for suicide, and you can see this bubble is much bigger. This is related to suicidal ideation, thoughts of death, and many of our clients have suicidal ideation or desire for suicide, thoughts, I'd be better off dead. And so the two factors in that side of the equation are this burdensomeness and disconnectedness. On the other side is capability of suicide, and that's the acquired capacity for lethality. So we'll sometimes talk about that as fearlessness, or it's two factors: fearlessness and pain tolerance. So it's the overlap among these that places a person at risk for a serious attempt or suicide. Now, what is important to know in this is that these are not chronological or sequential. It could happen this way, where you start with desire and then you move into capability. We see this happen over time, where clients may have the desire for suicide, and so they are self-harming, and or they have some non-lethal suicide attempts, where they then, over time, by virtue of their behavior, start to acquire capacity for lethality. But what we also can see is that capacity for lethality, you may already have that. And then on top of that capacity for lethality, you develop a desire. So it can move either way. So the way that I explain this is that I usually start with a riddle. And the riddle goes like this: what do people with eating disorders, military veterans, and veterinarians have in common? So the answer to that is that they all have an acquired capacity for lethality. So you're like, wait, what? Like that? How does that happen? That doesn't seem that way on the surface. Well, let's start with military veterans. That one's a no-brainer. They have an acquired capacity for lethality by virtue of their military experience. Think about this acquired capacity for lethality as being at death's door in different ways. And so that one makes sense. They're on the front lines. They've had these experiences that sort of desensitize them to death. They've seen it up close and personal. Okay, but then what about eating disorders and veterinarians? How do they acquire capacity for lethality? Well, eating disorders, if you look at the behaviors themselves, they are flirting with death. So these are very violent behaviors: purging, overexercise, especially on top of injuries. You can look at other behaviors too that may be common in eating disorders, and not necessarily eating disorder symptomology, but things like self-harm. So these are things that desensitize you to death. a lot of eating disorder clients will say things like, I mean, I've been told 10 times over I should have died. Like my potassium levels were so low that no one should have been walking around with those potassium levels. And so up close at death's door, those are things that desensitize them. Okay, let's talk about veterinarians. Whenever I talk about this, my son is a veterinarian. You'll be glad to know that as part of his training in vet school, that they had training around their risk for suicide. This is a group that has a high suicide rate. Warning signs, how to get help, ways to get connected, things like that. So I really liked that as part of his training. But why? Why veterinarians? Well, think about it. They are up close and personal with death on a daily basis, putting animals to sleep. And so, again, they get desensitized to death. I thought about this recently because I'd had a client die by suicide. Well, we actually weren't sure. She'd overdosed, and we didn't know if it was suicide, if it was intentional or accidental. And I was just beside myself over it, as you can imagine, as many of you, if you've experienced it, I sometimes say there's two groups of therapists: those who have had a client die by suicide, and those who haven't. And when you've had a client die by suicide, it changes the fiber of who you are. I will never forget the first client that I had who died. And it still stays with me. And so those of you who've had that, but I talked to my son that day and I'd said, oh my gosh, I feel like I can't even work. Like I'm just beside myself. And he said in sort of a nonchalant way of like, oh yeah, I forget that that's a really big deal. Like, my patients die every day. I was like, oh, that's horrible. I know it's a very different comparison, but the fact that he just said that with such nonchalance made me think, oh gosh, that's an example of that, like up close and personal with death, so that it really does kind of lose its sting, so to speak. So it's something to think about in terms of these other professions that may place people at risk. So anesthesiologists have high rates, dentists have high rates. And these are people that might be putting people to sleep, and so they're kind of up close and personal at it doesn't take much more to kill a person versus just putting them to sleep. Morbid stuff. Okay, so what we need to know though about this, why this is important, is that we need to understand the client in front of us and what is their capability. That is the question that we should be asking more often than we do, and more often than in probably the way that we were trained. All right, so let's move into suicide risk assessment. I love this question from Ed Schneidman. How willing am I to be inconvenienced by a person's response to two important questions? Where does it hurt, and how can I help? I love this. When I think about asking a client if they're having thoughts of killing themselves, thoughts of hurting themselves, I have to think about this question that Schneidman asks, because again, we are human. How many of you have experienced this? I used an example of like, it is a Friday afternoon. You have one more client, 4:00. At 5:00, you're getting in the car to go to the beach. Your family's waiting. Everything's packed. You're going to be on vacation for a week. You've been waiting for this, all summer long. And you ask the question, and they say, yes, I want to kill myself. my brain would kind of split in half. My first response, again, I'm human, would be like, no, I'm about to go on vacation. That sounds horrible, but we are human. And I have to acknowledge that part of me so that I can be up close and present with this other part of me that says, this is the most important thing I'm going to do. This might be the most important thing I ever do. This is this client's life and death. And I have to be present for that. And I want to be present for that. But I have to acknowledge the other aspect of me and give some compassion for that part of me so that I can be present. And if you've experienced those things too, you can have compassion for yourself on both sides. So, what we're going to talk about is first, what not to do. First, we want to start with self-report checklists. You can use self-report checklists. This might be something like the PHQ-9. Please use it. We use it. But you can't use that just by itself. It needs to be used in concert with other assessments. And then we'll talk about no suicide contracts. Those of you who are younger in your younger in age or younger in your training, you may never have been trained on no suicide contracts. Thank goodness. But this is how we used to be trained. I'll tell you what it is. But sometimes there's still some organizations that use no suicide contracts. So I do want to talk a little bit about that if you ever work for an organization that requires those. So let's start though with self-report checklists. Nothing wrong with self-report checklists. It's a good part of a comprehensive assessment, but they should not be used in isolation. It should just be looked at one aspect of the integrated assessment. So PHQ-9, great. Beck hopelessness inventory, great, but don't use that alone. But let's talk about no suicide contracts. I can get on my soapbox about no suicide contracts. Studies have found that no suicide contracts are ineffective. So let me explain what a no suicide contract is. A no suicide contract is when you have a client say, while I am in treatment with Dr. Siegfried, I contract that I will not hurt myself or try to kill myself. And then they sign it, and then I would sign it. And then we're like, oh, yeah, my work there is done. They're safe, right? I'm saying this a little tongue in cheek. But that is what we used to do. If you look at the history of no suicide contracts, because I have, it's like, where did this ever come from? Because there's no, like, if you look at what it does to the therapeutic relationship, you'd say, why would someone do this? Or when you look at that these are not protective in terms of litigation, why would you do this? What I'd say is on the litigation piece, those of you who've been trained that this is protective, actually, now that the AAS, the American Association of Suicidology, several years ago, made a statement on the ineffectiveness of no suicide contracts and have recommended against the use of no suicide contracts, I would say this would hurt you in litigation if this is what you did. So why? Where did these start? Well, it started with a case study in 1978 where a published case study, a clinician utilized this with a client and reported that it was helpful with his client, that they'd made this contract, that they'd made this commitment, and that it ended up being the way that he moved through his suicidality. That case study became the basis of what became best practice that never really was best practice. So we really recommend against the use of no suicide contracts. Instead, and we'll talk about this, we talk about safety planning. Some of you may say safety planning, safety planning, same thing. I mean, no suicide. No, it's not. In safety planning, or a safety plan, there's never anything on there that says, I promise I'm not going to hurt myself while I'm in treatment with Dr. Siegfried. So that's a big difference. So we'll talk about that. So let's talk about what to do. We're going to dig into this. We're going to talk about a comprehensive risk assessment, and then we're going to talk about risk level interventions based on that assessment. Now, when I talk about a risk level assessment, there's been a lot of debate around risk level as being the most effective way to understand suicide and prevent suicide. So over the last several years, there's been a push, even within the American Association of Suicidology, to move away from risk level designation. Yeah, that's big. I feel like I'm saying something really radical again. Why? Because there's been no indication that there is agreement around the different levels of risk, especially in terms of higher levels like moderate and high and elevated. And what's more important is the things that we put in place to create safety. And what's more important is collaboration, connection, compassion in terms of suicide prevention, rather than focusing on identifying risk. So I feel like in some ways, in going over this, I'm talking out of both sides of my mouth, because this is still what's recommended. So we are, I'm presenting this comprehensive risk assessment as what is best practice at this time. But I will not be surprised if over the next few years, we start moving away from risk level identification, because the debate is that we spend so much time identifying risk, we're not spending enough time identifying ways to protect and prevent. All right. So when we look at suicide assessment competencies, these are the important aspects of these competencies. Oh, let me backtrack for a second. The suicide risk, even though I was saying I'm talking about out of both sides of my mouth, the suicide risk assessment that I'm going to share today is one that moves toward this collaborative, compassionate assessment that focuses more on interventions versus just identifying whether the client needs to go to the hospital. So it is moving in that direction, but it still does include risk level identification: low, moderate, high, or elevated. Elevated or imminent. So I did want to mention that. So we, as part of these are the competencies that are put forth by the AAS and the SPRC, the Suicide Prevention and Resource Center, that anyone who is assessing suicide is competent in these areas. And so that's looks a little bit overwhelming and daunting. But what I will tell you is that what we're going to talk about today is going to meet all of these competencies. So the suicide risk assessment that we recommend, in addition to the Columbia screener, as to clarify, you can use a screener like the Columbia that may identify if there needs to be further assessment. But this risk assessment is that collaborative interview, that semi-structured interview that can help get an idea of some of the components of suicide. which include, remember, with Joyner's model, we had desire, which had burdensomeness and belongingness. Then we had capability, and then we wanted to look also at intent. This has all of this in here, including then protective factors, which is an important aspect of determining risk. So at the end of today's presentation, I should have mentioned this at the beginning, you're going to get a QR code that's going to have all of these slides, but then we'll also have some questions that you can use as part of this semi-structured interview to assess for each of these aspects. And we'll also include a bunch of other handouts that might be helpful. So these are the aspects of the interview. So what we're going to do is dig into each of these to get an understanding of what we're asking and what each one is comprised of. So we'll start with desire. So we're starting over here on the left side with suicidal desire. And what I have here is a breakdown. We separate this into green, yellow, and red. So there's components of desire. If we go back, these are the components of desire that I have written out here. So we're looking at each of these. Does the client have suicidal ideation? And we separate these into green, yellow, and red. What I also have in your handouts are some different ways to ask questions related to each of these components. When we ask about suicidal ideation, we always want to be direct. We're not going to beat around the bush. We're not going to say, have you had thoughts of not being here anymore? We're going to say, have you had thoughts of killing yourself or wanting to kill yourself? We're going to ask that directly. What we know is asking questions around this have no impact on increasing suicide risk. What I would say is the opposite, actually. When we ask directly, we're able to show that we can hold this space for the client and we can be with them in their experience. We're not afraid to ask. So we'll ask that directly. Have you had thoughts of killing yourself? And if it's passing or if it's regular, it's a constant, you'll identify green, yellow, or red. The same for psychological pain. This is also psychache, so you can use the term psychache for this question. Feeling trapped. This is really important because when we think about the World Trade Center analogy, you feel trapped. There's no way out except to jump. This is a common feeling before someone tries to kill themselves. We want to ask about hopelessness. We know that is a pivotal factor. Helplessness, that burdensomeness question. We may want to ask this in different ways to get at those different flavors, like I said. And then we want to ask about feeling connected and belonging. That's that last one. And we can ask about, have you felt alone, unseen, unknown? That relates to that question. So what we'll do is ask these questions and we'll rate each of these as green, yellow, red for the client. Then we're going to go to capability and we're going to do the same thing. We're going to ask about previous attempts. The number one risk factor for death by suicide is previous attempts. This is one of those like riddles or GRE questions that kind of blows people's mind, is that most people who die by, most people who attempt suicide do not go on to die by suicide. Many people have attempts that don't die. But the majority of people who die by suicide have had previous attempts. So that's one of those things that that it is one of those riddles. It's not, I don't have to think that just because this person has attempted suicide, well, that's it. It's over. They're going to die by suicide at some point. The majority don't, but the majority of people who die by suicide have attempted. So we need to think of it in that way. So we want to ask questions around previous attempts. People sometimes feel nervous about asking these questions. Often it's because the client doesn't want to talk about it. This is often the worst day of their lives, right? So they don't want to dig deep into this. It's upsetting to them. We do need some information. And the reason we need that information is that we need to know if there's been an increase in lethality with each suicide attempt. We want to also know how lethal was, even if they only did it once, how lethal was it? So we'll want to ask questions in terms of what was the method that you used. I ask questions of, did you stop yourself? That's always a good protective sign if a client stops themselves. Or were you interrupted? Did someone find you? Did someone walk in? Not so good in terms of lethality. Did you require hospitalization, not just a psychiatric hospitalization, but a medical hospitalization based on the method that you used to attempt? Were you in ICU? Things like that. So you'll want to know how these attempts have progressed. You do. The only thing you want to be careful here in terms of asking questions is sometimes clients will romanticize suicide, sort of the way that clients with substance use can romanticize their substance use of like, oh, that like was such a beautiful time, so you do, if you see them like falling into like romanticizing it and like, and then my family, it was the first time ever that they really took me seriously. You can't avoid you going down the romanticized path, uh, because that is something that can increase suicidal ideation. But in terms of asking these questions from a more curious fact finding, these are very safe questions. You also want to ask around about if they've ever had someone in their life die by suicide. One of the things we know is that there is a genetic component or biological component to suicide beyond depression. So if they've had a family member die by suicide, that does convey a higher risk for suicide than if they didn't. So that's just important to know if they've had a parent die by suicide or a grandparent die by suicide. The psychological or more sociological piece is if they've actually witnessed that. And the closer they were to that event, that has more impact. So I mean, if they found the person or they were that's much more up close and personal. Or it could be that it was their grandfather who died by suicide, but we all went to the house after that. Those are things where this has more of an impact than if their grandfather died by suicide before they were born, let's say. Remember that I think of this capacity bucket, I think of acquired capacity as a bucket, and that the events that go into it or experiences that go into it can increase your capacity. And there's events that go in there. So if I'm a client, I self-harm, that's going in there. I purge, that's going in there. I use IV drugs, that's going in there. But also violence that's happened to me goes in there. It doesn't convey as high as risk, but let's say I've been assaulted, that goes in there. Let's say that I have other traumas, that goes in there. So it's important to know if you have a history of experiencing violence, Or if you've had an experience of violence toward others, that conveys risk. So we'll ask some questions about that. Here, we want to look at both violence toward others and violence that they're experiencing. We want to ask about availability of means. We want to ask if they're intoxicated. We know that the majority of suicide or fatalities by suicide occur during intoxication. We want to know if, even if they're not intoxicated now, if they are abusing substances. Have they had a lot of shifts in mood, good or bad? Because sometimes when people move into a manic episode, this can, even if it's, feelings of euphoria, those significant shifts in mood can be pivotal. Decreased sleep is a big one. The majority of people who die by suicide lose sleep in the nights prior to the attempt. If the client also seems out of touch with reality, we'd be wanting to look at that. So I have questions that will help guide you on how to ask these, and then we'll rate those green, yellow, or red. And then we want to look at intent. So do they have a suicidal plan? Have they engaged in preparatory behavior? So given away their belongings, written a suicide note. Those may be some, arranged their funeral, made sure that their will is up to date. Those would be preparatory behaviors. And then do they have an expressed intent to die? I want to die and I'm going to die. There's nothing you can do about it, would be something more in the red. And so that would be intent. We also want to look at protective factors or buffers. And these are really important and things that sometimes we miss. So we want to look at, does the client have immediate supports, social supports? Are they engaged with the therapist? Do they have core values or beliefs that are protective against suicide? That suicide's never the answer, kind of thing. That can be protective. Do they have a sense of purpose in their life, that their life serves a purpose? Do they have future plans? And do they demonstrate an ambivalence for dying? Meaning, do they say, I want to die? Or maybe they say it this way, I don't want to live, but I also am afraid of dying. That's an ambivalence that can be protective. So let's talk about this in action. So in terms of scoring, and when you do this, when you score this, you'll need to use this as an instruction manual at first. So when a client has, all you need in each of the categories, each of the buckets, is one to meet criteria for that bucket. So you only need, sorry. So sorry, that's not true. Let me go back. I'm used to doing another screener. So for this, let me say it again. If 3 or more factors are endorsed as yellow or red, sorry, I'm used to doing training on a psychosis inventory over the last couple of weeks. Block what I said. You need to have 3 or more factors that are endorsed in the yellow and or red category for that component to be present. So if we look at desire, if that person, for instance, has suicidal ideation in the yellow, psychological pain in the red, and hopelessness in the yellow, that person would meet criteria. Or if they just had 3 in the yellow, 3 in the red, whatever combination, they need to have 3 or more. And if they do, they meet criteria for that, that bucket. If they only have one bucket, they'll be in this lowest tier, moderate to low risk. If they have two, they have, three in the yellow and red in desire, three in the yellow and red in capability, then they'll be automatically in this second bucket, moderate to elevated risk. If they have all three, they're in this elevated or imminent risk bucket. Now, what determines in each of these tiers whether or not they're low or moderate to elevated, elevated or imminent, is the presence or absence of buffers or protective factors. So in this bottom tier, if client just has desire and they have many protective factors, they'd be low risk. If they don't have many protective factors at all, then they would be moderate risk. Same for this. If they have moderate risk, they would have many. If they have two categories where they meet criteria, they'd be moderate. If they had many buffers, they would be elevated if they had no buffers. If they have all three, they have red, yellow, three reds, yellows in all three categories, they're automatically elevated risk. It doesn't matter if they have any buffers or protective factors. What would determine whether or not they were elevated or imminent is the degree to which they could create safety. What I want to make clear, and we'll talk about this in part 2 of our training, if y'all will have me back, is that we treat elevated risk at an outpatient level. Elevated risk is best treated at an outpatient level. These are people that might have desire, capability, and intent, but they can create safety. If they can create safety, then they don't need to go to the hospital. Hospitalization, imminent risk, is for creating safety, and it's needed sometimes. If they can't engage in means reduction, if they can't utilize coping skills, if they aren't willing or able to reach out for support when those urges arise, they would be imminent risk. So we need to make that distinction, and hospitalization should be used in those situations. So let's talk about a case study here of Caroline. Caroline is an 18-year-old gay female. She uses she, her pronouns. She has a history of alcohol abuse, major depressive disorder. She recently attempted suicide by cutting her wrists. She just completed a 15-day inpatient treatment. She had one previous suicide attempt by overdose at age 15. Her parents are involved, but they are non-accepting of her sexual orientation. So that's an important aspect. She has a girlfriend, but it's a tumultuous relationship. And in fact, they'd broken up right before her suicide attempt. She has a very supportive brother, but he's younger. And so that does make it difficult in terms of her feeling like she's a burden to him. She is starting college at a prestigious university in the fall. So sometimes that can be looked at as maybe good future planning, but it also could be a potential stressor. So when we look at this, for Caroline, when we completed the joiner on her, what we saw is that after this suicide attempt and after she came to us, she was having passing thoughts of suicide. She was still having that intolerable psychological pain that she was carrying with her. She didn't understand how she was going to carry this burden and not feel accepted by her parents. And she felt trapped. She didn't see a lot of options. She felt some hope because she was excited. She thought, maybe if I can move out when school starts, I won't be like in the house with my parents, and that will help me feel more accepted. She felt some control, again, more related to moving out. She famously said, and she kept saying this, that one of the things that led to her suicide attempt was that she felt her parents would rather have a dead kid than a gay kid. ugh, that always gets me. And so she felt like her parents at least would be better off without her. She didn't feel that way about her brother and didn't feel that way about her girlfriend until when they broke up, that shifted. She felt some mixed feelings around feeling alone. She felt some distance from others in that she felt close to her brother, but not her parents. So what we see here is that desire for sure is present. She has 5 in the red or yellow category. So, whoops, desire should be present. So we marked that yes. Is capability present? So capability, she is, we asked these questions. She did have a grandfather who died by suicide, but it was before she was born. She did have previous attempts, and this attempt where she cut her wrists was significant. She needed stitches, and she cut in the long way versus the horizontal way. She did have a history of substance use. She wasn't using then. She had anxiety. She had some sleep disturbances. So here we are again over here where capability is also present. When we look at intent for this client, she has no intent. So vague, no plan, no preparatory behaviors, no intent to die. So intent is not present. She was in the green on all of these. In terms of buffers, she does have some buffers, and she has one support who is her brother. She wasn't sure of whether or not to count her girlfriend. They were back together at that point, but she was counting her brother. The piece that was important here is that she didn't have any core beliefs that would stand in the way. She thought suicide could be a good option if needed. So for this client, we ended up making her elevated risk. Why? Well, she's in this category where she had desire and capability. Even though she had buffers, she had just discharged from inpatient, and we know that conveys a higher risk. So we put her at elevated risk based on that recent discharge from the hospital. So she was at our PHP level of care and was able to really work on these aspects of suicidal drivers that we'll talk about more in a minute. So let's talk about what do we do based on risk level. So we'll start with no or low risk. Something that's important is that we should create a safety plan for every client that comes through our doors, regardless of whether they have suicidality. That's why we call it a de-escalation plan and safety plan. And the reason we do this is that clients may be low risk at the time that you're meeting with them, but a lot can happen between this week and next week in terms of their risk. And if you haven't talked about what to do in those situations, they may be, at a loss of how to cope. So we want to use this de-escalation plan that can help guide them if suicidality arises. So when we look at a de-escalation and safety plan, we use Stanley and Brown's. I've included it in your handouts, and it looks like this. So you'll include warning signs, coping strategies, people in social settings that provide support and distraction, people you can ask for help, agencies that you can call for during a crisis, and then ways that you can make the environment safe. You'll use this for the step 6, just for those individuals that are high or moderate or elevated risk. And you'll also ask for those clients who are moderate and elevated risk, one factor that's important to them and is important to them in creating a life worth living. For moderate risk, we're going to do the same thing. We're going to use this safety plan, and we are going to, though, complete that bottom half that I showed you. We're also going to have this as an area of focus on the treatment plan beyond just depression. We'll have a specific area of focus as it relates to suicidality and how we're going to address that. We're also going to engage in means reduction. This is the most important aspect that we can do. If the client has urges or their plan includes medication, we're going to find ways to create safety around medications. If they want to use weapons, we'll want safety around those. My recommendation always is to create safety even around things that that aren't part of their plan. So let's say they want to overdose. I'm still going to ask about weapons and finding ways to create safety around weapons, even if that's not part of their plans. We don't want to engage in a power struggle here. From a safety perspective, we often say, oh my gosh, I just want to create the most safety, get rid of all the guns. And that often is not an option for clients. I used to work in the VA, and it would never be an option for someone, many veterans, to get rid of their guns. And so you have to come up with ways to create safety that meet the needs of the client in front of you. And it doesn't have to be drastic always to create safety. So with moderate or elevated risk, we're going to want to use these bottom 2. So this is an example of Caroline's. We looked at, for her, these were the warning signs, these were the coping strategies, people she was going to ask for help. She was also going to use 988 or the lifeline. And then we had things around medications and weapons for her that were specific. We had no guns in the house. The parents had bought a safe where they kept her medications, and they were doling out medications on a daily basis. She also had a safe where she could put items that were of harm, and she could close it, and they were the ones that could only open the safe. And then the thing that was most important to her was college. And so that was something that was giving her hope. If someone is elevated risk, we're going to want to consult at that time to make sure we're factoring out, ruling out imminent risk. And so we're going to want to continue to do regular assessments with this client to see what factors have changed over time. And we definitely are going to want to have this as an area of focus on the treatment plan, where we are directly intervening around suicide. And we'll talk about that in part 2 of the training. For imminent risk, if a client is imminent risk, there's some do's and don'ts. The do's are: do not leave the client alone if they're in your office. Someone must be with them until medical assistance arrives. And if you're in a virtual session, do not get off of the virtual session. You should be calling 911 on your phone while the client is in front of you. You also, you may say, Nicole, why are you even saying this? We'd never do this. Never say never. This comes up more often than you think. Clients often ask to be transported to the hospital. And they'll say, if you could just take me to the hospital, I'll go. Please just don't make the police come. It was traumatizing. They put me in handcuffs, which is horrible, but it shouldn't do that. But that's what happens sometimes. And so, out of the goodness of your heart, you'll say, okay, I'll transport you. Never transport someone who is suicidal. It's not safe to them or you. I've heard horror stories where clients have jumped out into traffic or swerved the car on the way. Should never be an option. Some questions that you want to ask are, is this person psychotic or intoxicated? Are they able to follow a safety plan? Are they motivated to act on thoughts? Are they able to give up means? And are they currently intoxicated? And if they are so, do they have an attempt while intoxicated? And are they having difficulties taking their medications? And so these would be indicators that hospitalization may be necessary. As part of that conversation with around hospitalization, we want to make sure they know it's for safety, because oftentimes when clients leave the hospital, they report feeling hopeless. They thought they were going to be better. They thought this was treatment. So we're always clear to say hospitalization is for safety, to get you to a point for us to treat this together when you return. All right. So the last piece I wanted to briefly touch on is postvention. And after a suicide attempt, it is important for you to take care of yourself, to have supervision around this. It is important for you and your client to talk through what happened if they come back to you. This becomes prevention. And this is an important aspect in terms of breaking the cycle of continued suicide attempts. All right. So the next thing in part 2 that we will talk about is interventions for chronic suicidality. So I have a 2-hour training on those interventions for what you do with a client who struggles with suicide. I want us to have some time for questions. I know we're right up against time, so we can stay on a little bit longer if people have questions, if we want to give a good 10 minutes. I also want to make sure that you all have access to our slides and our handouts. And so this will, if you use, this is a QR code, just put your phone up to this and click on it. It will take you straight to the folders with a lot of goodies for you to take back with you, including the slide deck and the Joiner suicide risk assessment questions and some interventions. All right, so questions.
Yes, if you have any questions, go ahead and pop them in the chat now. I'm noticing in the chat some people have clients, so feel free to drop. Thank you for attending. We'll stay on for just a few more minutes if there are any questions that trickle in the chat box. But I just wanted to say we've had quite a few of these webinars, and everyone here is so kind and interactive in the chat, so I really appreciate it.
I love that. I know I wasn't able to look at it while I was going, but I kept seeing them pop in. So I love that. I'll look at those afterward.
Excellent. Okay, we do have one question from Elise. Any advice on assessments if this comes up in a couples or family session?
Oh, that's a great question. And that does happen at times. And I would separate out the client in those situations, because there may be some they may not want to be forthcoming with their spouse depending on the situation. typically, in couple sessions, we don't meet individually, but in this case, I would. And then would bring the spouse back in to talk about what we would, so they can be part of safety planning. Um, but definitely would assess for suicidality, even though you are seeing them as a couple. I would assess individually.
Yes, okay. One that's also very closely
Yeah,
related, feelings on letting parents and friends transport someone who's at imminent
yeah,
risk, or is that too
yeah.
risky?
I we have that come up quite often. They can make that choice. I always make sure it's clear that we've recommended against it, and I will tell families, I understand why you want to do this, and I, as a parent, would want to do the same thing. It is very risky, depending on the client's impulsivity, and our recommendation would be for you to follow the ambulance. You can choose not to follow that recommendation, and I would just make sure that's noted in my note that I recommended against it.
Got it. Thank you.
Yes, you're so right. There is ambulance transport is expensive, and the way people are treated oftentimes is inappropriate, when depending on the state you live in. So there is risk in that way. There, you can call non-emergent medical transport that can cost less, and so we've done that at times, where the the this is in California, but that transport can be less expensive, and still supportive.
Excellent. Awesome. Well, thank you all so much for attending today. Again, this was recorded, so we'll be able to send that out. Make sure to scan the QR code, and we look forward to part two as well, hopefully. Thank you so much, Nicole.
Wonderful. Thank you, everyone, and have a great Friday.